So, Hallie, what are the important factors dealing with postoperative care for patients that have had emergency treatment?
Well, people who come to see us for emergency care are oftentimes, they've been in pain for a few days. They're distraught. They're stressed out. They're obviously not in a good mood. So it's very important to have proper communication with these patients because you have to really make sure you explain to them what is it that they should expect or not. And know that most of the time they're not going to listen to you, so it's probably best to have it in writing to give it to them so they know what to expect. Clearly, when somebody comes in with a huge abscess or comes in a lot of pain, they can't expect that whatever we do for them would be like a switch on and off button that, the anesthesia wears off and it's suddenly, roses and everything is beautiful. It's still going to be sore possibly for a few days. So it's important to keep that in mind, communicate that to them. Now, if you're doing a pulpotomy, and the patient has significant pain, it means that it was just a misdiagnosis. She did a pulpectomy, not a pulpotomy. It wasn't enough. There's still remaining tissue in the pulp. The diagnosis was, or the treatment didn't quite fit that diagnosis. The diagnosis was a little bit of a deeper level of irreversible pulpitis. There was partial degeneration of the pulp in the radicular pulp that then you just kind of ignored, and that's why the pain persists afterwards. That's the important thing to have the patient understand. As I think that's probably the most important part. In terms of any kind of medications to use postoperatively, there are really two things that are used primarily in endodontics for patients that have emergencies. And one is either the antibiotics that you would use or analgesics, right? Okay. So that is really the key. The question is, do they need antibiotics? And I'm a big proponent of not using antibiotics unless they're completely and clearly indicated. And those are cases in which the patient is febrile and has signs of systemic infection. The best antibiotic is the procedure that you just did, which is a pulpectomy. That is the treatment because the bacteria that is beyond the root end can always be handled by the body as long as the source is addressed. That is the whole essence of endodontic therapy. So if you can do the definitive cleaning and shaping required and place calcium hydroxide in the root through a complete and thorough pulpectomy, there is no need for antibiotics because the bacteria that's out there will very quickly be done with the patient's immune system, which brings on the next thing is what is the patient's medical history, right? So that's a significant thing. If you have a patient that is immune compromised or has a medical condition in which their immune system is not going to be able to get rid of the abscess, they have uncontrolled diabetes or, they're under immune suppressants for a kidney transplant or something severe, then it would be obviously prudent to have antibiotic coverage postoperatively, but still yet not proven, let's face it. Unless there's signs of systemic infection, that's not clear. Now, one of the things that I do, I must tell you, Dennis, is from a management point of view, I may give a patient a prescription for an antibiotic, and I would tell them not to fill the prescription. It gives the patient the comfort of knowing that they have that option, but I explain to them. It's all about just spending an extra couple of minutes and explaining to people and communicating with them that this stuff is not good for you if it's not indicated. Only 2% of the population have post-op flare-ups, and in those cases, then you would end up needing to take it. That's according to a study by Walton. And so this way they have it. And at the same time, then they would feel they feel that they're having too much discomfort, it's not getting any better, then they have an antibiotic to take. But I tell them not to take it. So also on the analgesic front.
Well, before you go any further, though, I'm not letting you off
the hook
so easy. No, I'm not letting you off the hook so easy. Let's say that you do feel that an antibiotic is warranted.
Oh, what do you give?
I want to know what you give.
You want to get specific.
I want this audience to understand what they need to do.
So what you need to do is, I always start from PenVK. I mean, PenVK is the tried and true basic stuff that you want to use, right? And that's geographically different. In parts of the world, because of the overuse of antibiotics, PenVK is not really effective. But based on some recent studies of antibiotic sensitivity, PenVK is still fairly good in terms of coverage for high 80% of the microflora that you can find in an endodontic infection. Okay. So according to that study, I think it was 87% or something like that is covered by penicillin. Now, a little bit of a higher percentage is covered by amoxicillin, and obviously further even with augmentin. But then again, you don't want to give that strong stuff off the bat, especially, first of all, because most of the time they don't need the antibiotic. So you got to do the treatment first, the pulpectomy. Then go with the coverage that covers the most and it's the least, it's more specific. So you don't end up killing everything in the body. The flora, the biome in the gut is an important organ in the body, and we need to make sure that we respect it as we're now understanding more and more its role in the overall physiology and our own health. From many different perspectives. So we don't want to kill those bugs unnecessarily just because we have this, this unproven need to just give antibiotics for anybody who has a dental infection. So I start with the more specific PEN-VK. Yeah. If the patient somehow ends up needing the antibiotic, they've filled the prescription and they end up taking it and they're still not getting better, then you would have to move that up to amoxicillin, or if somebody has a problem with it, with amoxicillin, or then you give them augmentin. Now, if somebody's allergic to penicillins, which would then basically preclude all three of these, I would go with clindamycin. And depending on the severity of infection, I would start with basically 150 milligrams 4 times a day, or go with 300 milligrams if they have really a big abscess that's out of control.
Go back to the penicillin.
Yeah.
At what too many
what
times?
dose?
Yeah, because too many times it's not given at a proper
enough.
dose.
Very good point. If you're going to give the antibiotic, you got to give it the proper dose. Right. And with the penicillin, I usually start by 500 milligrams. I usually start with a loading dose of 1,000 milligrams, and then 500 milligrams 4 times a day. Okay. On the amoxicillin, you could go with 3 times a day of the 500 milligrams. Or up the dose and then cut it down to twice.
And do you do a loading dose with that as well, or no?
On the amoxicillin, I may do too. I mean, it has to do with the kind of infection they have. But I just want to, I hope this part is being clear. That antibiotics are not the answer.
Yeah, we got it.
The answer is a pulpectomy. Antibiotics, if you're going to end up not treating a patient because you don't have time, probably it's best to refer them as opposed to give antibiotics. And if you're going to refer them, don't give them antibiotics because that could, unless you have a diagnosis. If you don't have a diagnosis, then you could mask the problem. They end up coming to see me as a specialist, and now they've taken the antibiotic, and that they have coverage, and now I can't figure out what was the main source of the problem.
Yeah, I think there's nothing quite as difficult for a patient who didn't receive treatment but may have been given an antibiotic and then has an intestinal problem.
Yes,
I've seen for weeks.
Yes.
For weeks as the result of it.
Especially with some of these, if you give clindamycin. I mean, if somebody's allergic to penicillin and they're taking clindamycin and they end up getting a pseudomembranous colitis.
I mean,
people can die from that.
Saying. And what you're telling people, I think, is absolutely correct.
But what I'm saying is not just because of pseudomembranous colitis. It's also because of the overall importance of the biome in our everyday health. Now, analgesics, another important thing. Obviously, these patients are going to probably be still in a little bit of pain for a little bit, obviously a lot less, hopefully, than what they came in with. But it takes a little bit of time for things to reach equilibrium, and that's important to communicate. Many people go with narcotics. I think narcotics are also overused. And again, the problem with narcotics is that it's actually the leading, it's the gateway drug to people who end up becoming dependent on these types of analgesics and then move on to other things. So it's best not to give narcotics. And in fact, studies now prove basically 400 milligrams of ibuprofen, which is 2 Advils, and 500 milligrams of acetaminophen, which is 1 extra strength Tylenol, in combination has been shown to be more effective and stronger, in fact, than Vicodin. So I think it's really incumbent upon us as responsible practitioners to make sure that we don't put patients in jeopardy by giving them narcotics unnecessarily when most of the problem can be addressed with NSAIDs and Tylenol. Because the NSAID works at the site on the tooth where there's inflammation, and the Tylenol works in the brain to shut down. So at 2 different centers.
Perfect combination.
Yeah, they don't interact, and at 2 different centers you get the pain response, and that's the best way to go.
I think the other thing is going back many years ago when we used to use drugs more commonly.
In which way?
I didn't think of it that way. People really get sick from these combinations of narcotics that you give them, and their tooth feels better, but they feel worse.
Yeah,
So-
yeah, absolutely. It's just it's not the right thing to do. It affects people in very negative ways, in many different ways. And lastly, the continuity of care. Emergency procedures, oftentimes, as we mentioned, you have calcium hydroxide in the tooth, and for the patient, the pain goes away. So out of sight, out of mind. And they just forget to come back to restore the tooth. They come back, a year later, and that tooth is unrestorable because of the caries that is present. So again, that goes back to the communication part. Patients that are in pain, they're not going to listen to you. They need to be followed up. It's our responsibility to make sure that they understand, ahead of time through.
So let's say that you
proper
tell a
communication.
patient that they need to come back to you. In your office, do you have a follow-up system?
Yes, we do.
Just take a half a second and tell us how that works. What would you advocate that the person listening to us right now do in order to be sure that patients don't fall through the cracks?
Fall through the cracks. Of course, I'm an endodontist, so it's a little bit different. What I do as an endodontist is when the patients leave, they always get a postoperative form which explains what they need to do, what to expect. The stuff that I talked about, I tell them in the operatory, but we give it to them in writing as well. In there, it writes down, also it explains the fact that they need to come back for the continuation. A month later, usually, we send patients another letter that says that hopefully you've restored the tooth. Hopefully by this time they've come back and we've completed the root canal. So at this point, I would assume that they would kind of understand that, oh my God, I should have had the root canal. so we automatically send reminders.
And your system is set up for it. It's part of what you do. But in a general practice, it should be routine.
Yeah.
That the patient's given something as to explain what was done.
Yes, and what's next.
And what has to be done.
Yeah, what's next is an important thing for them to know. And I guess understanding the importance of why it's next. Because patients oftentimes think, well, I don't have pain. Why do I have to go now?
Yeah.
Maybe I'll just wait till the pain comes back. If they understand that this procrastination is going to actually cost them the tooth itself, that whatever they invested into getting this procedure done to be out of pain will be nullified, and then they'll have to start, not from scratch, but they could actually lose a tooth. They will be more motivated to follow up and do the right thing. All right, so I think that's pretty much does it here for our access and for emergency treatment.
Yeah.
So let's come back and draw some conclusions from what we've learned so far.
Okay.